Okay, so we are going to talk about some X-linked recessive disorders. Um, we'll start with Duchenne muscular dystrophy. We'll talk about Becker muscular dystrophy, and then we'll go on into a discussion of hemophilia. Now, some authorities believe that the terms recessive and dominant are not as applicable to sex-linked disorders because often what you see in carriers, female carriers of these diseases, is that they still show some symptoms, but because of X inactivation, um, an incomplete dominance, they aren't as severely affected. But for all intents and purposes, they are still classified as sex-linked recessive, X-linked recessive disorders. Duchenne muscular dystrophy involves a single gene involved in the production for a protein that is called dystrophin. And dystrophin has a protective effect on skeletal and cardiac muscle. It's not common, but it's not as rare as some other disorders, 1 in 3,300 to 1 in 3,500, just about exclusively males. It occurs in all races and ethnicities, and it occurs frequently from de novo or spontaneous mutations. If we're talking about straight inheritance, your book has provided these 4 Punnett squares. Now, the bottom here, rare and unlikely scenarios. Duchenne muscular dystrophy usually kills people by the time they're in early adulthood, and by the time they're able to find a mate and reproduce, they're usually pretty severely impacted by the disease. So these are unlikely scenarios. When we talk about Becker, they might be a little more applicable. But here's a Punnett square for 2 individuals who do not have alterations on their DMD gene. If we're talking about straight inheritance, the risk for inherited DMD is 0 out of 4, but we don't know what the risk for spontaneous mutation is. In this scenario, in the upper right, mom is a carrier for DMD. She has 1 normal allele and 1 allele that does not make enough dystrophin. Dad has a normal X chromosome. He has a normal Y chromosome. In this pattern, if mom gives her normal X, the child does not have any disease or carrier status. They get a normal from dad. They get a normal from mom. The boys will get a Y from dad and a normal X from mom. But if she passes on the defective gene, in this scenario, dad gives the normal X. She has the defective X chromosome. She's a carrier. And if they have a son, the defective X is the only X he has. The Y will not protect him. He will have Duchenne muscular dystrophy. So chances are 50% normal, 25% carrier, 25% having Duchenne muscular dystrophy. Now, these other patterns, not as relevant because most men with Duchenne muscular dystrophy do not reproduce. If it were a Becker muscular dystrophy instead of Duchenne, and they weren't diagnosed until their 20s, which does happen, then it would be possible, in which case dad has a defective DMD gene, mom has a defective DMD gene. Dad has a Y chromosome and mom has 1 normal X. When mom passes on the normal X, if dad passes on the defective gene, they will have a female with carrier status. If mom passes on a normal X and dad passes on the Y, that is a child with normal dystrophin production. If, on the other hand, mom has a defective X, dad has a defective X, there is that possibility that they could have a child with Becker's muscular dystrophy because they both have defective X chromosomes. And there's also a chance if they have a boy, mom's defective X with dad's Y equals Becker's muscular dystrophy. So that would be the pattern in Becker's, more common. You would have risk for Becker's muscular dystrophy would be 50%, carrier status would be 25%, and unaffected would be 25%. It would be a boy. This is probably the least likely scenario, 2 individuals with Becker's muscular dystrophy. I'm not even going to work that out because the likelihood is so incredibly far-fetched. All right, so in Duchenne, back to Duchenne, muscular dystrophy, pathophysiology, the dystrophin protein is like a little wrapper, and it keeps the muscle strands in place. The little, when a muscle contracts, there are these little proteins that have to snap back and forth like a rubber band. Sometimes they break, okay? Dystrophin prevents that from happening. It gives them a little bit of stability, sort of like a coated elastic. Mutations in that gene either lower the amount of dystrophin or they make that dystrophin non-functional, and you don't have that protection, so muscles become unstable and they break down when they contract. Now, in the beginning, body can compensate a little. Remember that skeletal muscle, I know I said this in like week 2, there are some tissues that divide and reproduce as they get damaged, and some that do not. The ones that did not, we said, were cardiac muscle. We talked about nephrons, neurons, and skeletal muscle. So the only way that a muscle can grow once it's mature is to get bigger in size. You're not going to make more cells. So if a cell dies, it is replaced with scar tissue, and the function of that cell is lost. The other tissues can sometimes hypertrophy and compensate for a little while, but if they're all hurting, eventually, one by one, they're all going to start to die and become replaced by scar tissue. So, signs and symptoms. How do we diagnose Duchenne muscular dystrophy? It's not part of the state-mandated newborn screen because there is no cure. Remember, that was one of the conditions. We had to have something we could offer people. Usually what happens is a parent will bring their child to the pediatrician or pediatric provider because they're seeing things like the child falls up the stairs or they walk on their toes to compensate for instability in their pelvic girdle and hip muscles. Or the child who was sitting up and had normal muscle strength and muscle tone is now all of a sudden can't sit up on their own. So somewhere at the ages of 2 and 5, you might see that. They bring the child to the pediatric provider. Pediatric provider might run different tests. One of those tests should be a creatine kinase, which is elevated when you have muscle damage. So, especially if we're not looking at extreme exertion, somebody didn't climb a mountain or run a marathon, if they have high levels of creatine kinase, something is abnormal in breaking down the muscles. You can do a biopsy to confirm the diagnosis. What you will see is fibrous tissue in place of muscle cells. And there is a genetic test. Usually the application of that is to establish carrier status. And if a person with muscular dystrophy of one kind or another wants to reproduce, or a close relative of theirs does, we can use gene testing to find that out. A lot of times if you have a sibling of a male with Duchenne muscular dystrophy, the female sibling may have inherited the mutation, which was new in the sex cells of the parents, and she would want to know her chances of having an offspring with muscular dystrophy. The muscle weakness is noted in the neck, and that's why sitting up is harder. Hip girdle, and that's why walking is harder. And you see the toe walking, it's like a compensation mechanism. So problems with walking, sitting upright, become apparent somewhere early in childhood. It's usually diagnosed very early. Skeletal muscle, cardiac muscle, and the muscles involved in breathing are affected, and that's what shortens your life expectancy, particularly the cardiac damage. Healthy cardiac cells are replaced with scar tissue when they get overexcited. Most of these folks do not live past the age of 25. There is no cure. Child can be offered steroid therapy to reduce inflammation of the muscle cells, and it'll slow down that rate of degeneration. We can do things to put less stress on the muscles, weight management, using diet and mild to moderate exercise. You definitely do not want to encourage any intense activity that could accelerate the loss of functional muscle cells. Cardiac and respiratory supportive care, we might do medications that help the heart. Beta blockers might be indicated there in respiratory support. Sometimes people need oxygen. Positioning is important so that their muscles don't have to work as hard to expand the lungs and get good gas exchange. But those are some things we do for Duchenne. Now, Becker is basically the same pathology. It is the same gene. It is the same protein, but it's manufactured in large enough amounts to make the progression of the disease slower. It will still progress. It is still degenerative. It will still kill a person. But frequently, we don't see the symptoms until the child is older, about the age of 10 for most people. There have been reports of people exhibiting their first symptom of the disorder at age 40. A longer lifespan, the average lifespan is somewhere around 40, 45. Some people living into their 60s. It is still degenerative. It is still progressive. It will still eventually result in death, usually from cardiac causes. Individuals may not be diagnosed until after they have already fathered a child, so genetic counseling should be offered once it's discovered. Okay, so we're moving on to the next X-linked disorder. It is classic hemophilia. Classic hemophilia, very similar in inheritance, if not in symptoms. It is another monogenic single gene disorder. It's caused by any one of a number of mutations in the F8 gene. F8 is called that because it codes for the factor 8 clotting factor. If you remember the clotting cascade, the process of making a blood clot is like baking a cake. You have a number of ingredients, and if any of them is missing, your cake is not going to come out right. It's the same with blood clotting. To make a clot, you need a lot of different factors, one of which is factor 8. Now, a particular mutation in that gene can be unique to a family. You only see it in one bloodline, but it's the same pathology. Maybe the bases are different from one family to the next, but you're still going to end up with the same problem. Transmission is X-linked recessive. Incidence 1 in 5,000 live births, almost exclusively males, occurs in all races and ethnicities. And just like Duchenne's, has a high spontaneous mutation rate where you've never seen it in a family before, and now here it is. Signs and symptoms. Female carriers may actually have slightly increased bleeding because they have just a little bit less factor 8 in their blood. So they might be the ones that have heavy periods and they're always bruising. They might have a history of postpartum hemorrhage, but nothing that would indicate that they're carriers for hemophilia. Not all female carriers will have that tendency, but some will. Some of the things that go with classic hemophilia, it can involve extensive joint damage. If there is bleeding into the joint capsule, it will damage the joint. Variability is based on the levels of factor 8. It is not just some or none. There's a spectrum of how much factor 8 is produced based on the specific mutation to that gene. Life expectancy with factor 8 therapy, we replace the factor 8 that their body doesn't make, is about 65 years. Here's my little Punnett square. I didn't use the books one because it was too complicated. If you have normal X and a Y, that is a normal male without hemophilia, and you have a mom who is a hemophilia carrier, you have one normal X chromosome and one chromosome that does not make factor 8, or that does not have the right gene to make enough factor 8. And your results will be like this. You have possibility homozygous dominant. You have your XY homozygous dominant. You have heterozygous recessive, which is a carrier. And then you can have the single X chromosome that is affected, and that is a male with hemophilia. So if mom is a carrier, marries a normal male, she will pass this disease on to her sons, and her daughters have like a 50% chance of being carriers. Here's a pedigree analysis, and this is how you can sometimes use a pedigree to figure out patterns of inheritance. This is Queen Victoria's family. The British family, royal family, had a lot of hemophilia. In fact, it impacted their succession line. So here's Queen Victoria marries Prince Edward, has a daughter, single daughter, who is a carrier for hemophilia. This daughter marries a man without hemophilia. They have 1, 2, 3, 4, 5, 6, 7, 8, 9 children. They have 1 child with hemophilia. It is a male. Male dies an infant. Well, no, he doesn't die. Look, he gets married and passes on trait to a carrier. But you see, none of the females actually have hemophilia. Everybody who is affected with the disease is male, and only the females are carriers. And you see it skip generations sometimes. You see it, this whole line of the family, none of their descendants had it because none of them were carriers. And that is very common pattern with X-linked recessive. It's one of the ways you can use a pedigree to find out the patterns of likely inheritance. Signs and symptoms: bruising and excessive bleeding in response to any trauma during infancy, except what the literature says is circumcision, and that could be because there's some placental transfer of factor VIII to the newborn. Once that wears off, they're not protected anymore. So you don't necessarily see it while they're in the hospital. They have their circumcision and there's hemostasis. But later on, if they go to have a blood test or an injection, vaccination, something like that, they might have bruising and bleeding from that. Interestingly enough, you don't get petechiae in areas of trauma. You can get extensive joint damage because there's bleeding into the weight-bearing joints. The stress that's on the joints from normal activity sometimes causes little micro tears. If there's bleeding into them, it will damage the joint. You'll have a family history of excessive bruising and bleeding in some cases, but definitely an individual history. The pedigree may reveal pattern of inheritance. You can do F8 gene sequencing to identify the mutation. It is not included in the newborn screening. They usually wait for symptoms to appear before they do anything about it. There is a treatment, though. Regular infusions of factor VIII, and definitely increased infusions of factor VIII if there is any likelihood that they will bleed or any injury or accident. Liver transplantation could result in a cure, but it's, that's one of those risk versus benefit things. They rarely do it just for this disorder. Resources and support. You can refer a patient with hemophilia to the National Hemophilia Foundation. There are special treatment centers called Hemophilia Treatment Centers, HTCs, that are expert at helping people with hemophilia. And there is a support group called the Blood Brotherhood. It's for males with hemophilia, since that is the majority of people who suffer from it. We're going to finish up with vonWillebrand disease because even though it is not X-linked recessive, it is a bleeding disorder. So it kind of makes sense to lump it in. It is another single gene disorder. It's now caused by mutation on the vonWillebrand factor gene. The most common form, there are different forms of it. Autosomal dominant transmission, but you sometimes have reduced penetrance, which just means it does not express itself fully. Variable expressivity. Incidence is about 1 in 300 births. I will have to correct that slide. It occurs in all races and ethnicities and has a high spontaneous rate. This is another one of those things in the recipe for a blood clot. Endothelial cells should produce vonWillebrand factor if the gene on chromosome 12 that codes for that is functioning. vonWillebrand factor also activates platelets. So there are 3 types of vonWillebrand disease. Type 1 is most common and most mild. Type 2 produces normal amounts of abnormal vonWillebrand. So it's producing vonWillebrand factor, but it's not normal vonWillebrand factor. Type 3 is the most rare and most severe, and this is autosomal recessive inheritance, where the person really makes literally no vonWillebrand factor. Reduced penetrance in this disease may mean that the trait is suppressed in some individuals, so they will still have normal amounts. Usually it's underdiagnosed. Honestly, From what I understand, the most common scenario is when a woman comes in, have a baby, she has a postpartum hemorrhage. And when you start talking to her, she goes, "Oh, yeah, I've always had heavy periods. Um, do you have a history of nosebleeds?" They'll start talking about that. But sometimes the first time it's even recognized is in the event of a postpartum hemorrhage. And even then, it's not always tested for. Um, but you do get easier bruising, easier bleeding, frequent nosebleeds. If you were to have a tooth procedure or dental procedure, you can have excessive oral bleeding. They can be anemic from heavy periods if they're female. How do we manage von Willebrand disease? Desmopressin is a drug, can be given in a nasal spray. It gives immediate but short-lived help um, by putting in like pre-made clotting factors or von Willebrand like factors. If you know that this person has von Willebrand and they're coming in to have a baby or surgery, you can manage that bleeding more aggressively and make sure that you have blood products available for transfusion. And you would avoid any unnecessarily invasive procedure. Obviously, you would caution this person against things like contact sports, anything that would increase the risk of bleeding. And that is about all for that. We will take a break and come back with chondroplasia.